Thank you. It's now time to switch to the next speaker. The next speaker is Fernando Otaiza. Fernando works in the Ministry of Health of Chile, Santiago. He's in charge of the National Program for Healthcare-Associated Infection Prevention. He also participated as a member of the WHO for the Safe Surgery Save Life project. And he will be talking national strategy about a national strategy to reduce C-section SSI and how we make efforts to sustainable for this. Thank you.
Thank you very much, and thank you very much for this invitation. For us, it's very important. We have been working in infection control in Chile for the past 34 years. And we're always willing to show what we're doing elsewhere. We have had a good opportunity to do this in the Americas. So now to have this opportunity to speak about this in France is particularly interesting for us. I have been invited to talk about reduction and sustainability of C-section surgical site infection. But I'm going to talk about how this is part of a larger initiative that is a national initiative to prevent infections. So the first thing you will hear me speak about is about the national NIPC program, where the obstetric infections is just one module or one part of it, and some of our results. Just to let you know that Chile is probably a medium-income country. Most of the health care is provided by the public insurance and the public service. It's around 70% of all health care is done by the state to the population. And of the 400 facilities in the country, half of the facilities are directly dependent from the Ministry of Health. The program, in brief, started in 1982. It's directed by the Ministry of Health. It has permanent staff just for infection control. We are 3 people there, and we're hiring a 4th person this year. It continues. It hasn't had a year of stop. We worked all the time, and it's national. It provides regulations for the public and private sector. It's regulated by law. There is a law that is a law of the rights of patients, that in the article number 4, it says that it's a duty of the state and a right of the patients to have health care with prevention of infections directly, and then another issues. So we have a law that obliges us to work on this. And we work in close strategic alliances with universities, scientific societies, and lots of leaders in the community, but on the healthcare community. The program has 5 main components: organization, surveillance, guidance, training, and external evaluation. And our main principle, it's always been document your success. Whatever you do, say what worked, what went well, what could have done better, and then go first for the easy win. And then you start adding up into more complex strategies. So, having said that, early in the program, we defined what our objectives are. I'm not going to go one by one, but the most important one is to prevent the healthcare-associated infections. And the way we measure this is by rates. We have 2 main strategic objectives. One of them is to prevent device and procedure-associated infections, and the other one is outbreak-associated infections. I'm not going to be talking about outbreaks in this presentation. It's a whole new universe. And also we prevent infections that are transmitted to and from patients to healthcare workers. The strategy is a multimodal strategy. It always was this way. We have a surveillance system. It's centered on local action. This means that every hospital has to be doing things to prevent infections. Both private and public sectors have to do this. So we have a surveillance system. I'm going to describe it in brief. Technical guidelines that in Chile, they all have a regulated mandatory component. They're not just recommendations. We have training at several levels that is done simultaneously with these 2, And we have an external evaluation system that is looking at compliance of everything else, everything I mentioned before. And also, when a hospital has a particular problem, it will have an individual healthcare facility monitoring, in which experts will go to the hospital and contribute in case of prolonged outbreaks or other serious situations. I'm remembering when the program started, the first things we had to take care of is how to start the thing, and we found that the sterilization systems all over the country were failing. So the day I walked in, there was already an ongoing process of normalizing sterilization services. And this is very relevant for the objective of this presentation, because everything that we did during the first 5 to 10 years was normalizing sterilization systems, which is a huge amount of money dedicated to buying equipment and training people. Everything else has been what we have been doing as the program. So we have up to date, the IPC programs are established in all hospitals. These have trained infection prevention control doctors and nurses. It's in the public and private sectors, and is regulated by the law. And we have 3 main laws and regulations that provide us a framework that we can make, and we can supervise any institution to have this working. A surveillance system. The surveillance system is probably the only especially dedicated personnel that we have introduced to the program. It's mostly done by nurses. It's an active surveillance system with selected indicators, which, as you probably are all doing, it requires weekly chart review of patients at risk and laboratory results in order to find infections, applying standardized definitions and methods. Nowadays, it's an online reporting, and we get the reporting from the public sector every month. The private sector does not report to the Ministry of Health, but the law says that they have to have the data available, so for any time the authority asks them to provide them. And every time we measure how good we're doing with the system, we find that we are reporting around 80% or more of the infections. And in surgical site infections, probably it's a little bit higher, and nowadays, because of the change of healthcare system, that patients are leaving the hospital quite early, we might be losing a few cases there. And we provide for the whole system national reference rates that are used for benchmarking, so hospitals can compare their results and identify priorities for next interventions. Secondary to that, we have national guidelines and norms. We have lots of them, lots of them. We have most of them are evidence-based, and most of them have a regulatory component. They're just not recommendations. But the main areas we are involved with is sterilization, disinfection, the standardized precautions, and the prevention of device and procedure-associated infections. And here is where we build in the particular interventions for infections such as surgical site infections, puerperal endometritis, urinary tract infections, and others. I have to say that probably half of these guidelines nowadays have to do with outbreak management. We also are involved in containment of the antimicrobial resistance and the preparedness for epidemics and disasters. Simultaneously with the surveillance system, we have a training strategy. In the beginning, we had 12 infection control nurses, and it was clearly not enough for the 100 public hospitals. Nowadays, we have 1 nurse for every 250 beds all over the country. But these people need to be trained, and not only trained in surveillance, but trained into several aspects of infection control, including how to educate adult population, how to supervise the compliance of practice, and surveillance and outbreak management. So we have divided our population, our target population, into the IPC professionals and need to be high-profiled, well-trained, creative people. Then we have a second group, which is the clinical professionals, which is the doctors and nurses. This is done locally. And finally, the last strategy we are implementing is the mandatory training of every chief of department in infection control with 80 hours minimum on infection control. This has been a very interesting strategy because these are the people that are finally taking the decisions, making the decisions for a clinical service where everything should be happening. And to provide this complex training system, we have at least 3 main online courses, plus universities and scientific societies cooperating with this. And the last component is external evaluation. So what it's mostly is it's a checklist that is applied by regional health services by trained people. It's non-punitive, and they go into every aspect of infection control and provide a local report on how they're doing, and then they write the report online, and it's collated with the data of every other assessment, so we may know how we're doing in different hospitals and all over the country, what areas need special attention. And this has been happening very early in the program, and nowadays it's probably one of the most interesting activities because the hospital staff, particularly the infection control staff, are always looking at us to come and check what they're doing, and this way they can have an interesting document in which they can influence their CEOs to improve care and the program. So having said this, everything is happening at the same time. So when we talk about surgical site infection and then the C-section infection, everything is happening at the same time. It's not a particular strategy for this area, but it has the advantage that the population is clearly identified, and it's a very similar age, and of course they're all women, so it's very easy to, we don't need too many systems for comparing hospitals. Having said this, when we look at our infection rates, this is a follow-up between the year 2000 and 2014. This is a selection of 6 different infections. We can see that we have reduction in all of them, and this reduction has been considerable for these 15 years, that it has a variation between 35 and 80% almost. And one of the most interesting infections that we are controlling to date is the surgical site infection. And I have to remember at this point that when we had our 20 years meeting, my old professor came in and said he had to present infection control in surgery. And he said that he had to remember that during the 60s, they had 30% infections at one time in the hospital. And they had to close the operating theaters in order to see what was going on. And then in the past year, infections were always less than 2%. So when you look at these kind of differences, you see that we are doing well in these aspects. Coming to the obstetric infections, data cases are, of cases under surveillance in the public sectors. This is the mean between 2012 and 2014. We are following up around 94% of all deliveries in the public sector. Of these, 40% are C-sections. And of the C-sections, 93% were followed under surveillance, and the surveillance is done during the hospital stay, and then their follow-up to the first nursing control that happens like 5 to 7 days after they are discharged. And then we calculate the rates of endometritis and C-section infections. And the particular activities and contents we use here is, first of all, we have the surveillance and feedback, which is happening monthly in every hospital and yearly from the Ministry of Health, and a set of guidelines, education, training, and supervision of practice. And the contents of these have always been antimicrobial prophylaxis, skin prep, cleaning of the site, the hair removal, clip, don't shave was the first slogan in this, and the use of antiseptics on the skin before the section, and also the use of sterile technique, both the sterilization of clinical materials to the hand hygiene. And this is our strategy for this, for C-section infection. This is what we've seen from 1996 to 2016 in Chile. We have seen a steady reduction in the C-section infections of a 65.5% in the period. We always mark the period 2008-2009 because we had a change in the reporting system, in the surveillance. So there is always a noise there that in the other infections, as you will see, makes it's louder. When we look at puerperal endometritis per 100 deliveries, according to the type of delivery, we see the same thing. We see a reduction of infections from 2% to less than 0.5%. I have to remember that before this period, when we did the first studies, our puerperal endometritis rates was over 6%. So this reduction is with a particular definition and a surveillance system. And so the impact in the time from the 80s to this time has been much more. And we can clearly say that women that are having their babies now are safer than they were 10 or 20 years ago. And when we look at other surgical site infections, even though the graph is messy, but the reduction is obvious, from 2% to less than 1% in most of the cases. And this is some of the infections we are monitoring. We're monitoring around 10 particular surgeries in particular patient populations. So, although I have some more time, I have to say that as a conclusion, the national NIPC program has demonstrated reduction of the sites of the surgical site infections in Cesarean by 65.5%. That the reduction of rates is in all targeted sites of infections by the program, and the program is not a one sole thing, but it's a comprehensive program with local core components. The components we have in Chile are not that very different. They are allineated with WHO, but not the same thing. And we are working in our new system to alienate them more, so at least the wording represents and it allows us to measure similar things than the current core components. Also, we have to say that the program is multimodal, both national and local. We don't believe that you can do one thing. Actually, you can, but it's always necessary in order to have, particularly when it has to do with a set of people that have to change practice, that you need to involve different strategies, from surveillance and feedback of the results so they know what's going on, to have dedicated staff to follow up things with leadership. You need to have clear guidelines that we all know what we need to be doing at the same time, and several training strategies. We don't believe that there is one single one. We believe in a hands-on strategy, so we usually do it in small groups, discussing, having them make their own decisions, but following a general guideline that is mandatory. And the existence of an external evaluation that people look for. They like having supervisors to come and check that everything is in place, to show them where the gaps are. And we have been preventing all the time to have any punitive assessment. These things may change. We have different patient rights nowadays and transparency, and we have more litigant population. People want to sue the hospital every time they have a problem. So we have to be publishing data, and sometimes with a lot of detail according to the requirements of the public or the press. but still the hospitals understand that this is a priority. And also, we have a local NIPC that's required by law and regulations, and they have to comply with it. And as the last one, if we have to check at what our key factors are, I'd say that the continuity of the program for many years. When you have to establish something so complex, you need to have a follow-up and understand that there are times that people take in order to understand and then implement. We get impatient. We try to have them all at once. We're faster now than we were in the beginning, but we always have to allow a little bit of time for people to understand, adapt, and implement. We have good surveillance and reliable local data that people are very proud of. We consider it part of our legacy to the next generation. And we're always complementing the fact that we know what's going on. We have trained professionals. We have medical involvement in the local program. So there's doctors involved in every part of it. And we're always trying to prevent that this doesn't turn into a nursing or into a nursing care program, which is the tendency most of the time. The establishment of local multimodal strategies and the external evaluation has been fundamental for people to know how they're doing and see how to move the program forward. It has been documented, and they documented local impact, which makes people very proud of their work. And this has also been, according to everybody we have interviewed in Chile, one of the most important points of the program, that everybody knows that their rates are better now than before, and that they have done something in order to keep them there. So this is my team, and we have another person coming, and in their name and everybody else, thank you very much.
Thank you very much. The presentation is now open for questions. Is there any question in the audience? Please take the micro, introduce yourself. In French, it's possible. En français, si vous voulez.
Mais je ne parle pas français, monsieur.
Great, so it's even better. There is no barriers for questions. So I've got one. I will start. I've got two questions. First one is, what's the rate of C-section in your country?
Excuse me?
What's the rate of C-section in your country in comparison to...
the rates of
C-section. What's the rate, the proportion of women with C-section?
I'm not understanding the question, sorry.
So from the total number of births, what percentage would be via cesarean section?
Oh, in the C-sections? It's in the chart. It's less than 1% now, or around 1%. Let me check.
No, it's infection following C-section, but it doesn't matter.
You're talking about any infection, or because it's around 0.7% probably? All our data is in our webpage. I can't remember the exact figure. I should have, but.
Yeah. So in the UK, excuse me, our cesarean section rate of births is about 28%.
Oh, wait, the C-section is around 40% of all births. 40% of, this is another issue, and this is a very important issue, because there is a big discussion in Chile about the exaggerated number of C-sections for births. And this is even worse in the private sector, when it can go up to 70%. Huh?
So it's a very high rate. Yeah.
No, this is a different challenge which has nothing to do with infection control, but we are concerned with it.
So one question from Pascal Astagno.
Yes, another question. The reduction of your SSI rate is very impressive. I just wonder if what is the importance of surgical site infection after discharge? Do you estimate the rate of surgical site after discharging the hospital?
Again, can you repeat the question, please?
Pascal, can you repeat the question?
So what is important, because our surgical site
With the
infection...
microphone, yes. No, my question is, how many, do you estimate the number of infection occurring after the patient discharged in hospital?
That's a very good question.
Out of the hospital.
Very good question. This is always, nowadays, a woman that has a C-section will be 2 days in the hospital and then it's gone. So, and then we check her up and seven days after. It's usually around 20% and sometimes 16%. That is what we have found in some local studies. We're not doing, we don't implement and we don't ask people to follow patients after that because it's very expensive and we don't find many infections later. So we just follow until they come for the first control after birth, and that's all we can do because then they go who knows where and we lose them in the network. So it's around 16%. Very local studies, huh? I can't say at the national level. Thank you.
Okay. Please can we thank Fernando for his very interesting presentation. Thank you.
Thank you.